Assalamu alaikum. I'm Dr. Sidra Arshad, Assistant Professor of Physiology, with the fourth lecture, the series of endocrine physiology. I shall be discussing with you today two major energy metabolic hormones released from the endocrine pancreas. Those are insulin and glucagon. And I shall also be discussing the pathophysiology of diabetes mellitus. So this is the layout that we are going to follow after establishing the biological characteristics of these two hormones. I shall be describing in a little bit of detail the physiologic effects of insulin and glucagon. Then we are going to integrate the action of these two hormones and some other hormones in the overall energy metabolism. Then we shall discuss in a little bit of detail the diabetes mellitus, its pathophysiology, its signs and symptoms. And then we'll conclude by briefly looking at the insulin shock and hypoglycemia. In front of you is a diagram which shows you the structure of the pancreas. So pancreas are composed of two types of glands, exocrine glands and the endocrine glands. Located in the middle of the form of the islands of the exocrine pancreas are these endocrine glands. These endocrine glands, they are known as the islets of Langerhans. They are composed of 5 types of cells, and they are closely associated with the blood vessels. So the secretions, they directly pour out into the blood, while the exocrine glands, they pour their secretions into the ducts. So these cells are found in the endocrine pancreas. They are called alpha cells, beta cells, delta cells, epsilon cells, F cells or PP cells. They have their characteristic secretions. Alpha cells, they secrete glucagon. Alpha cells are also sometimes known as A cells. Beta cells, they secrete insulin and a protein which is known as amylin. Delta cells, they secrete somatostatin. Beta cells and delta cells are also respectively called B cells and D cells. Epsilon cells, they secrete another hormone which is known as ghrelin. F cells or PP cells, they secrete pancreatic polypeptide. There is quite an interesting interplay between these hormones. For example, the somatostatin, which is released from the delta cells, it inhibits both the alpha and beta cells. Similarly, insulin released from the beta cells can locally inhibit the release of glucagon from the alpha cells. So these cells are regulatory to each other as well. We'll start off by describing the structure and synthesis of insulin. So insulin is a polypeptide hormone. It is composed of 2 chains, alpha chain and beta chains, which are connected to each other via disulfide linkages or disulfide bridges. So this is the alpha chain and this is the beta chain. So what happens is that the gene for insulin is found on the short arm of chromosome number 11. It's transcribed and translated to the pre-form of a hormone. Just like all the polypeptide hormones, the initially formed protein is known as the pre-pro hormone. In this case, it is going to be known as pre-pro-insulin. This pre-pro-insulin undergoes post-translational modification where it is converted into proinsulin, which you can see right over here. This proinsulin is composed of A chains and B chains, which are connected to each other via this C chain, also known as connecting chain. It is then packaged in the Golgi apparatus into secretory granules or secretory vesicles, where it undergoes certain changes. Those changes are that the C chain is separated from the A and B chains. So the secretory granule, it contains proinsulin. Now it is known as proinsulin. It contains proinsulin along with the C peptide. So the final product that is excreted out of the B cells or beta cells is insulin plus C peptide. Importance of C peptide lies in the fact that in persons who are taking exogenous insulin, that is those with diabetes mellitus who are taking exogenous insulin, the level of C peptide can be measured to see that how much production of endogenous insulin is there, because insulin, once it is synthesized in the beta cells, when it will be released along with the C peptide. However, when we administer exogenous insulin, it does not contain the C peptide. So levels of C peptide can give us a clue about the functioning of the beta cells in cases of diabetes mellitus. So once this insulin is synthesized, it is released into the blood where it has a very short half-life. Next up is the mechanism of insulin secretion. It is quite important that what is the major stimulus for the release of insulin and how the insulin is actually released from the beta cells. We have seen it has been packaged into the secretory granules, but now it has to be released. What is the exact mechanism of that release? It is quite important and it is also a frequently asked question. What happens is that this is the cell which you can see in this diagram. This is the beta cell. What happens is that whenever there is increased plasma glucose, that glucose moves into the beta cells via this facilitative transporter, which is known as GLUT2 or glucose transporter 2. Glucose moves inside of the beta cells where it is converted into glucose 6-phosphate by an enzyme which is known as glucokinase. This glucokinase, it traps the glucose into the beta cell in the form of glucose 6-phosphate. This glucose 6-phosphate is then going to undergo glycolysis, Krebs cycle, and oxidative phosphorylation to produce increased amount of ATP. So the ATP is going to be formed. You can see right over here, this third step is the formation of ATP. When ATP levels inside of the cell are increased because of the transport of glucose into the cell and its conversion into the ATP, what is going to happen on this side of the cell? There are specialized channels which are known as ATP sensitive potassium channels. These ATP sensitive potassium channels, as their very name indicates, they are sensitive to the concentration of ATP inside of the cell. So in the presence of ATP, these channels are going to close. These channels are now going to close. Because of the closure of these channels, the potassium is not going to leave the cell. These channels were involved in the transport of potassium out of the cell, but in the presence of ATP, they close and the potassium does not move out of the cell. When the intracellular potassium is increased, the cell is undergoing depolarization. This depolarization, it opens up the voltage-gated calcium channels. These voltage-gated calcium channels, they open up and there is calcium influx. Calcium influx then mediates the exocytosis of the secretory granules which contain insulin along with the C-peptide. So exocytosis takes place and insulin is released into the blood. So this is the mechanism of insulin secretion. Begins with the movement of glucose into the beta cells via GLUT2 or glucose transporter 2. The glucose is trapped inside of the cell by the action of an enzyme which is known as glucokinase. Glucose is converted into glucose 6-phosphate, which then undergoes glycolysis, Krebs cycle, and oxidative phosphorylation to produce large amount of ATPs. This ATP acts on the ATP-sensitive potassium channels. How does it act? It simply closes these channels. When these channels are closed, the potassium it stays inside of the cell and the cell undergoes depolarization. In response to this depolarization, the calcium channels, the voltage-gated calcium channels, they open up and there is influx of the calcium. Then there is calcium-mediated exocytosis of the secretory granules, which contain both the insulin and the C-peptide. Now, how does insulin act on its target cells? Insulin acts by binding to its specialized receptors, which are known as insulin receptors. Now, the structure of insulin receptors is quite interesting as well, and it is worth knowing. It has two components. The receptor has two components, alpha subunits and beta subunits. Alpha subunits and beta subunits are chemically connected to each other. The alpha subunit serves as the binding site for the insulin molecules. Insulin it binds with the two subunits, two alpha subunits, and when this binding occurs, there is autophosphorylation of beta subunits. This autophosphorylation of beta subunit, what does it do? It causes activation of tyrosine kinase. So insulin receptor is a tyrosine kinase linked receptor. This tyrosine kinase is closely associated with the beta subunits, which when they are phosphorylated by the binding of insulin with the alpha subunits, the tyrosine kinase is activated. Now, a couple of enzymes, actually more than that, are phosphorylated or activated as a result of this tyrosine kinase activation. Most of these enzymes are known as insulin receptor substrates. These bring about the relevant actions of insulin hormones along with the phosphorylation of some other enzymes. Some of those actions are that in certain cells, for example, skeletal muscle cells, adipose cells, and in cardiomyocytes, there is increased transport of glucose into the cell by the activation of these enzymes. How does it take place? When insulin acts on its receptors and tyrosine kinase is activated and insulin receptor substrates and phosphorylation of enzymes, it occurs. It causes the translocation of specialized facilitative transporters into the cell membrane. Those transporters are known as glucose transporter 4. So we have seen one type of glucose transporter earlier on, which was glucose transporter 2, which was present in the beta cells. So here the glucose transporter 4, it will be translocated into cell membranes of some cells, for example, adipocytes, skeletal muscle cells, and cardiomyocytes, just to name a few. And then certain other effects will also be taking place. There will be protein synthesis, fat synthesis, glycogen synthesis, growth, and gene expression. So insulin is a metabolic hormone which is anabolic in nature. So these anabolic effects will be occurring along with the facilitating the movement of glucose or transport of glucose into the cells, especially those cells which are purely dependent or mostly dependent upon insulin to move the glucose into the cells. Because of its actions on carbohydrates, lipids, and proteins, insulin is known as an anabolic hormone. It brings about its actions over a period of time. There are certain actions which occur immediately after the insulin binds to receptors. These actions include increased transport of glucose, amino acids, and potassium into insulin-sensitive cells. So there are certain cells in which, in the presence of insulin, the transport of glucose into those cells is increased. These cells include adipocytes, skeletal muscle cells in the resting phase, and the cardiomyocytes. What happens is that when insulin binds to receptors, there is increased translocation of glucose transporter 4 into the cell membranes through which insulin moves into the cell through facilitated diffusion. So skeletal muscle cells, they require insulin for efficient maximal glucose uptake during the resting phase. However, when they are exercising the movement of glucose transporter 4, it is not insulin dependent. They can increase their uptake of glucose in the exercise through other mechanisms which involve the movement of glucose transporter 4 into the cell membrane that is not insulin dependent. Insulin also increases the uptake of amino acids to form the proteins, to synthesize proteins, and potassium is moved intracellularly by increasing the activity of sodium-potassium ATPase pump. So the insulin increases the activity of that pump, so potassium moves into the cells. Intermediate actions include stimulation of protein synthesis and inhibition of protein degradation. So these are anabolic effects. That protein is synthesized, however, its degradation is being prevented by insulin. It also activates glycolytic enzymes and glycogen synthase so that glycogen is synthesized and the excess glucose is stored as glycogen in both the skeletal muscle cells, which are resting, and the hepatocytes. It also inhibits phosphorylase and gluconeogenic enzymes so that glucose levels are not increased any further and the glucose is actually stored. The delayed effects, which take about hours to occur, they include increase in messenger RNAs for lipogenic and other enzymes. These are the anabolic actions of insulin. So when we talked about the uptake of glucose facilitated by insulin or insulin-sensitive cells, it is pertinent to know the glucose transport mechanisms. The glucose is transported into the cells independent of insulin in most of the cells. For example, in neurons, they are able to take up glucose even in the insulin deficient states. So the transport of glucose in the neurons, it is not insulin dependent. So these transporters are important to know. There are glucose transporter 1, 2, 3, 4, 5, 6, and 7. These transporters, they are different from the sodium-dependent glucose transporters, which you must know from the gastrointestinal and renal physiology. So glucose transporter 1, it is found in almost all of the cells of the body, including neurons. Glucose transporter 2 is found, as we had already seen, in the beta cells of islets. It's also found in liver, epithelial cells of small intestine, and kidneys. Glucose transporter 3 is found in brain, placenta, and kidneys. And now this important glucose transporter 4, right over here, it is responsible for insulin-stimulated glucose uptake. So one of the actions of insulin in certain cells, especially skeletal, cardiac muscles, and adipocytes, was that it causes translocation of glucose transporter 4 into the cell membranes of these cells so that they can take up glucose. So by this facilitated transport of glucose into the cells by glucose transporter 4, which is found in abundance in the cell membrane in the presence of insulin in these cells. Glucose transporter 5 especially transports fructose. Obviously, it will be seen in the jejunum where the fructose is being absorbed, and also in the sperms, which use fructose for their energy purposes. Then there is glucose transporter 6. It is found in brain, spleen, and leukocytes, while glucose transporter 7 is found in the liver. So glucose is transported into the cells via these transporters. Out of these transporters, the glucose transporter 4, it is stimulated by the presence of insulin, that it is translocated into the cell membranes in the presence of insulin in these types of cells especially. Let's see the effects of insulin on the major metabolites. Those are carbohydrates, fats, and proteins. So insulin, it promotes the uptake of glucose and its metabolism by the insulin-dependent cells especially. It promotes muscle glucose uptake and metabolism. The skeletal muscles during the resting phase, that is the digestive and post-absorptive phases, skeletal muscles are at rest, and at that time the insulin, it promotes the uptake of glucose into the skeletal muscle cells. Now this glucose is going to be stored majorly in the form of glycogen, which can then be used as an energy source by breaking it down into glucose during exercise. So at rest after meals, most of the glucose is stored in the form of muscle glycogen up to a limit of 2 to 3%. In the liver, even though the uptake of glucose by the hepatocytes is not insulin dependent, however, in the presence of insulin in the digestive and post-absorptive phases, in the presence of insulin, the uptake of glucose becomes even more efficient, and the liver is going to metabolize carbohydrates to the best of its abilities in the presence of insulin. So insulin promotes liver uptake, storage, and use of glucose. It establishes this by inactivating the liver phosphorylase enzymes. Insulin is going to bring about certain actions by inactivating or increasing the activity of certain enzymes. So it inactivates the liver phosphorylase. This liver phosphorylase is involved in the breaking down of glycogen, that is glycogenolysis. So if this enzyme is inactivated, glycogenolysis is prevented. So insulin is going to promote the synthesis of glycogen, and it is going to inhibit the glycogenolysis. Its breakdown is going to be inhibited. It also increases or stimulates the activity of glucokinase, which is an enzyme which converts the glucose into glucose phosphate. In this way, when the glucose is converted into glucose phosphate, it is trapped inside of the cell and it is not going to move out. So this glucose is now available to undergo glycolysis or to be stored in the form of glycogen. It also increases the activity of glycogen synthase. This is an enzyme which is involved in the synthesis of glycogen. The activity of this enzyme is increased by insulin. It also causes or promotes the conversion of excess glucose into fatty acids. So the excess glucose that is formed, taken by the cells, hepatocytes, it is also converted into fatty acids. These fatty acids are then converted into triglycerides, and these triglycerides then move out of the hepatocytes in VLDL, this form of VLDL, and they are deposited in the adipose tissue. So the triglycerides, they are synthesized in the liver, they are stored over there, or they are moved into the adipose tissue. At the level of adipose cells, so the muscle, skeletal muscle, the resting skeletal muscle, liver, hepatocytes, and adipose cells. These are the main players because these are cells which are involved in the efficient carbohydrate metabolism in the presence of insulin. So the insulin, it also increases glucose entry into adipose cells and other cells of the body. These are the effects of insulin on the carbohydrate metabolism. Insulin's effect on fats, they insulin increases glucose utilization by most of the body's tissues. So it decreases fat utilization and it acts as a fat sparer. So in the presence of insulin, cells are able to utilize glucose. It increases the glucose metabolism by the cells, and by this action, it spares the fat from being metabolized. It promotes fatty acid synthesis by increasing uptake by hepatocytes, which we had just seen. And when the glucose is present in the hepatocytes, it is converted into acetyl coenzyme A, which is then converted into fatty acids. Fatty acids then are used to form triglycerides. And in the adipocytes, insulin, it increases the activation or activity of lipoprotein lipase. Lipoprotein lipase is an important enzyme for the adipocytes to take up triglycerides. What does it do? It breaks them into fatty acids and glycerol because triglycerides are not directly taken up by the fat cells. They have to be broken down, and they are broken down into fatty acids and glycerol, which are then taken up by the fat cells. And here, when the substrates are available for the synthesis of triglycerides, these are then synthesized inside of the adipocytes by using fatty acids and glycerol from the glucose in adipose cells. So here, the triglycerides, they were made available to the adipocytes by the liver as well, and they can synthesize their own triglycerides by glycerol, which is formed from the glucose which they had taken up, and by the fatty acids, which they synthesize themselves. So this is the mechanism through which inside of the fats, the excess glucose is being stored in the form of triglycerides. And on the other hand, insulin, it inhibits or inactivates hormone-sensitive lipase. This is important because triglycerides now have to be stored. They do not have to be made available as fatty acids and glycerol to be used as an energy source. So to promote this storage, insulin inhibits hormone-sensitive lipase, which prevents the conversion of triglycerides or breakdown of triglycerides in the adipose tissue. Insulin also affects protein metabolism and growth. It promotes protein synthesis and storage. It is an anabolic hormone, so it promotes protein synthesis and also its storage. Insulin is also released in response to the certain amino acids in the blood if their levels increase. That is in the digestive phase, when the amino acids are absorbed from the intestines and their levels are increased, they can directly stimulate the beta cells to release insulin. So the insulin brings about following effects on protein metabolism. It stimulates transport of many of the amino acids into the cells. For example, valine, leucine, isoleucine, tyrosine, and phenylalanine. It increases translation of messenger RNA, thus forming new proteins. Also increases the rate of transcription, the both processes which are involved in the protein synthesis. These are facilitated by the insulin. It inhibits catabolism of proteins. So it is preventing the catabolism of proteins. It is increasing the or facilitating the synthesis of proteins and causing their storage inside of the cells. In the liver, insulin depresses the rate of gluconeogenesis. Insulin, it prevents the use of amino acid to synthesize no glucose or gluconeogenesis. It depresses the rate of gluconeogenesis. So the amino acids are not being used for gluconeogenesis. They are instead being used in the formation of proteins. Now, here is an important concept over here that insulin is required for growth. It is seen that insulin and growth hormone, they interact synergistically to promote growth. Neither of these two hormones can act alone to cause growth. Both of them should be present simultaneously to cause growth of an organism, to promote the growth of an organism. It can be explained by this graph. You can see over here that this graph shows the growth in terms of weight, increase in weight in a rat which had been depancreatized and hypophysiectomized. That is, the pancreas had been removed along with the pituitary gland. So that is, there is no source of endogenous insulin and endogenous growth hormone. So growth hormone, well established, it is involved in the growth of the body, and insulin, it also helps the growth hormone out with this process. As we have seen that insulin is an anabolic hormone, it is involved in the synthesis of proteins, so obviously it is going to take part in the growth of an individual. So in this rat, once the pancreas and the anterior pituitary had been removed, exogenous growth hormone and insulin were administered at certain points. It was seen that when growth hormone was administered alone, it did not cause much increase in the weight of the rat. Similarly, when insulin was injected alone, it did not bring about the increase in weight. However, when growth hormone and insulin were simultaneously given to that rat, there was a marked increase seen in the weight of that rat. So growth hormone and insulin, they show synergism when it comes to the growth of an organism. It is seen that growth hormone, it actually promotes the release or stimulates the release of insulin from the beta cells. Or does it bring about it? It causes the increase of plasma glucose. The increased plasma glucose is then going to stimulate the beta cells to release insulin. Now let's summarize the effects of insulin on the major tissues which are involved in the energy metabolism. These are adipose tissue, muscle, and liver. So in the adipose tissue, the insulin, it increases glucose entry, fatty acid synthesis, glycerol phosphate synthesis, increased triglyceride deposition, activation of lipoprotein lipase, inhibition of hormone-sensitive lipase, and increased potassium uptake. Increased potassium uptake is facilitated by insulin in a way that it stimulates the sodium-potassium ATPase pump so that more potassium is pumped into the cell. In the muscle, it causes increased glucose entry, glycogen synthesis, amino acid uptake, protein synthesis in ribosomes, protein catabolism is decreased. It decreases release of gluconeogenic amino acids so that gluconeogenesis does not occur. It also increases ketone uptake, increases potassium uptake. In the liver, there is decreased ketogenesis, increased protein synthesis, increased lipid synthesis. All of these effects, they are actually preventing the use of lipids as an energy source in the presence of glucose. However, the lipids should be stored for the use when the insulin levels are less, that is in post-absorptive states. Increased lipid synthesis, decreased glucose output due to decreased gluconeogenesis. There is increased glycogen synthesis and increased glycolysis, that is utilization of the glucose is increased in the presence of insulin. Generally, all over the body, the insulin is involved in increased cell growth. Discuss the actions of insulin. Let's discuss the control of insulin secretion. So there are certain factors which can increase the release of insulin from the beta pancreatic cells, and then there are certain factors which actually decrease the insulin secretion. So insulin is a hormone which is released in maximal quantities in the absorptive or digestive phase. That is when the intestines, they have digested and are now absorbing the nutrients, and the levels of these nutrients or metabolites is increasing in the blood. For example, when there is increased blood glucose, which has just been absorbed by the intestines, this increased blood glucose, it directly stimulates the beta pancreatic cells to release insulin, as we had seen in the mechanism of release of insulin. Just as glucose, blood-free fatty acids, they also stimulate the release of insulin. Blood amino acids, they can also stimulate the release of insulin, and there are certain gastrointestinal hormones which promote the release of insulin from the beta cells. These hormones are gastrin, cholecystokinin, secretin, glucose-dependent insulinotropic peptide, and glucagon-like peptide, which is also known as incretin. Glucagon, growth hormone, cortisol, and to some extent estrogen and progesterone, they also stimulate the release of insulin. All of these hormones, they increase plasma glucose levels, which then stimulate the release of insulin from the beta cells. The pancreatic islets, they are richly innervated by the autonomic nerves, parasympathetic, and as well as sympathetic nerves. Direct parasympathetic stimulation causes through acetylcholine, it also promotes the release of insulin, secretion of insulin from the beta cells, as well as beta adrenergic stimulation. Sympathetic stimulation has dual effect. It can promote the release of insulin, and it can also inhibit or decrease the release of insulin from the beta cells. If the beta receptors are stimulated, then there is the increase in release of insulin secretion. However, if the alpha receptors are stimulated, then there is decreased insulin secretion. You can see the beta receptor stimulation decreases insulin secretion. However, alpha adrenergic activity decreases insulin secretion. Then in the presence of insulin resistance, that is in type 2 diabetes mellitus, in obesity, there is actually increase in insulin secretion. The glucose, it is not being transported into the cells in the presence of insulin resistance, so its levels are high, which are continuously stimulating the beta cells to release more and more insulin, even if it is not able to exert its action. Then there are certain drugs, oral hypoglycemic drugs, sulfonylurea, for example. They also stimulate the release of insulin from the pancreas. They inhibit the ATP-sensitive potassium channels. Because of that inhibition, those channels, they do not open up. The cell is depolarized, which facilitates the release of insulin, as we had seen earlier. The factors which actually decrease insulin secretion, these are decreased blood glucose levels, which are seen in the fasting state, post-absorptive state. When the blood glucose levels, they are decreased, insulin secretion is decreased. In the fasting state, somatostatin is a hormone which inhibits or decreases the release of insulin. Alpha-adrenergic activity and leptin is also involved in decreasing the release of insulin from the pancreas. So this is how the control of insulin secretion is brought about with these factors. There is an interplay involved depending upon the metabolic state the body is in at that moment. So this concept is important over here, that the main factor which is involved in the release or secretion of insulin is the increased blood glucose level. So plasma insulin levels, if they are followed within minutes of release of insulin, which follows the blood glucose levels, it is seen that acutely when the beta cells are stimulated by any of these factors, especially blood glucose levels, there is an acute release of preformed insulin. So the levels are high acutely, that is within 2 to 3 minutes, the levels are excessive. Plasma insulin levels are excessive. It is brought about by the release of preformed insulin, because insulin is a protein and the new synthesis of insulin is going to require some time. But the initial increased levels, markedly increased levels of insulin which are seen, these are due to the release of preformed insulin which was stored in the vesicles. It is released. After some time, the release of insulin is actually decreased. However, there is a second phase of increased insulin release. In this phase, the insulin levels, they increase markedly. It follows after a few minutes, that is 20 minutes. You can see from this graph, about 15 to 20 minutes. After 15 to 20 minutes, there is a second surge of insulin. It is brought about by the release of preformed and new insulin. Now that we have discussed insulin, let's move on to glucagon. Glucagon is secreted by alpha cells of islets of Langerhans. It is also a polypeptide hormone. It is secreted in response to decreased blood glucose levels. Whenever there is reduction of plasma glucose, the glucagon will be released by the alpha cells of islets of Langerhans. There are certain factors which affect glucagon secretion. There are stimulators and inhibitors. Stimulators are amino acids, particularly those amino acids which are involved in gluconeogenesis. These amino acids are alanine, serine, glycine, cysteine, and threonine. It is also stimulated by some gastrointestinal hormones, for example, CCK and gastrin. Cortisol also causes the increase of glucagon. Glucagon is released in large quantities whenever there is exercise going on. Skeletal muscles, they require more and more energy, so the glucagon is increased. Glucagon actually increases the blood glucose levels. In cases of infection, other stresses, stress hormone, glucagon is also one of the stress hormones. It is increased by the beta adrenergic stimulation of the cells themselves. Then there are certain drugs, for example, theophylline, it causes increase of glucagon, and acetylcholine also increases the release of glucagon. Inhibitory factors include glucose. In the presence of adequate amounts of plasma glucose, the glucagon will not be released. Somatostatin also inhibits the release of glucagon as well as secretin. If there are elevated free fatty acid levels, the glucagon will not be released, as well as ketones, and insulin also inhibits the release of glucagon. Then there are certain drugs, phenytoin also inhibits the release of glucagon, alpha adrenergic stimulators, and GABA, it also inhibits the release of glucagon. So glucagon is glycogenolytic, gluconeogenic, lipolytic, and ketogenic. It is acting quite opposite to insulin because it is released in opposite conditions. That is, it is released when the blood glucose levels are low. So to increase those levels, it causes glycogenolysis, formation of new glucose, that is gluconeogenesis. It also makes available fats for energy utilization, that is, it is lipolytic, and ketogenic, that is, it increases the formation of ketones, which can be used as an energy source. Glucagon acts on its receptors, which are G protein linked receptors, especially stimulatory G protein linked receptors, and it mediates its action by increasing the cyclic AMP levels inside of the cells. So effects of glucagon on glucose metabolism, they follow the scheme that glucagon plus adenylyl cyclase in the hepatic cell membrane, it increases the levels of cyclic AMP. Cyclic AMP then stimulates the protein, activates the protein kinase regulator protein, which activates protein kinase. Protein kinase, it causes the phosphorylation, activation of phosphorylase B kinase, which converts phosphorylase B into phosphorylase A. This phosphorylase A, it promotes the degradation of glycogen into glucose 1-phosphate. Glucose 1-phosphate is dephosphorylated and glucose is released from the liver cells. So this is the mechanism of release of glucose in the presence of glucagon. When it stimulates the hepatocytes, the glucagon, it causes the release of glucose from the liver cells through this mechanism, which involves the second messenger cyclic AMP. Only a few micrograms of glucagon, they can cause the blood glucose levels to double or increase even more within a few minutes. So glucagon, it causes prompt increase in the blood glucose levels. It increases gluconeogenesis through activation of multiple enzymes that are required for amino acid transport and gluconeogenesis. Glucagon activates adipose cell lipase, which causes the excessive quantities of fatty acids to be made available as the energy source for the body. It inhibits storage of triglycerides in the liver so that fatty acids from the blood, these are not removed. It makes the fatty acids available for the body to use. It does not cause their storage. It does that by inhibiting the storage of triglycerides in the liver, so that fatty acids are made available for the other tissues of the body. Glucagon in high concentration, it also brings about other effects which are non-metabolic in nature. It enhances the strength of the heart. It increases blood flow in some tissues, especially the kidneys. It enhances bile secretion and inhibits gastric acid secretion. So these are some of the other effects of glucagon, which especially occur if the glucagon is in high concentration. So this is the interplay between the release of insulin and glucagon, as we had already seen that their stimuli were quite opposite. In the presence of increased blood glucose, the alpha cells, these are inhibited. However, beta cells are stimulated to release insulin. So the blood glucose levels, they are returned to normal because insulin causes the utilization of this glucose. In the case of decreased blood glucose levels, the alpha cells are stimulated. However, beta cells, they are inhibited, they are not stimulated. So glucagon is released and blood glucose levels are then returned to normal because glucagon, that it increases the blood glucose levels, which are then brought to normal. So let's just integrate these hormones into energy metabolism. Let's look at the phases. In the digestive phase, insulin secretion is increased because the metabolites are now high in level in the blood, so they have to be utilized. Blood glucose levels are increased and this glucose has to be utilized. Insulin levels are increased and glucagon levels are decreased in this case. So the insulin to glucagon ratio, which is used as a marker to see the metabolic phases the body is in at any particular moment. In the digestive phase, the insulin to glucagon ratio will be high because there is more insulin as compared to glucagon in this phase. Then in the fasting phase, the levels of insulin will be low because there is decreased plasma glucose at that moment. So the levels of glucagon will be high. So in this particular phase, the insulin to glucagon ratio will be low because there is low amount of insulin and high amount of glucagon. There are other players which are involved in the energy metabolism. These are growth hormone, cortisol, and epinephrine. So insulin, glucagon, growth hormone, cortisol, and epinephrine, these are involved in the energy metabolism. We are going to review them together one by one. So this table shows the major metabolic effects of insulin and glucagon, which we can use to summarize and revise those, and control of their secretion in various metabolic stages. So insulin, its effect on blood glucose is that it causes glucose uptake, glycogenesis. It inhibits glycogenolysis and gluconeogenesis so that it is decreasing the blood glucose levels. Its effect on blood fatty acid, these include it causes triglyceride synthesis and inhibits lipolysis so that it is decreasing the fatty acids levels. On blood amino acids, the insulin, it decreases the blood amino acids level by causing the amino acid uptake by the cells so that these can be used for the protein synthesis. Its effect on muscle protein is that of anabolism, that it is increasing the muscle protein by promoting protein synthesis and inhibiting protein degradation. So major stimuli for secretion are increased blood glucose levels and blood amino acids, which will be found in the digestive state. Its primary role in metabolism, it is the primary regulator of absorptive and post-absorptive cycles. That is when the person has taken a meal and it is being assimilated, it is absorbed, and immediately it is being made glucose and free fatty acids and amino acids in the post-absorptive states. These are being made available to the cells to be used for the energy, to synthesize proteins, and to be stored for later use. That is the post-absorptive stage, in which these metabolites are being stored. Glucagon, on the other hand, it causes glycogenolysis, gluconeogenesis to make the blood glucose levels high, make glucose available for the cells to be used, and it inhibits glycogenesis. It is not causing storage of the glucose. It is actually making available glucose for the cells. Its effects on blood fatty acids level is that it causes lipolysis. So the lipolysis is going to promote the use of fatty acids for energy purposes. It also inhibits triglyceride synthesis. It is actually causing the breakdown of fat, so the fatty acids are being increased in the blood. It does not have that much effect on blood amino acids. It is actually causing the gluconeogenesis. It is utilizing these amino acids does not have much effect on protein, muscle protein. Major stimuli for secretion of glucagon are decreased blood glucose levels and increased blood amino acid levels. Its primary role in metabolism, it involves regulation of absorptive and post-absorptive cycles in connection with insulin production against hypoglycemia. So basically, in hypoglycemic state, the glucagon levels are increasing, and which in turn stabilize or increase the blood glucose levels to prevent hypoglycemia. Now let's look at the effects of epinephrine, cortisol, and growth hormone. Epinephrine, it also increases the blood glucose levels. It will be increased in the states of emergencies, exercises, and fasting. So epinephrine, it promotes glycogenolysis. So it makes glucose available. Gluconeogenesis, formation of new glucose, it inhibits insulin secretion and it causes increase of glucagon. It does inhibit insulin secretion directly. However, indirectly, it may actually end up increasing insulin secretion by increasing the blood glucose levels. Its effect on blood fatty acids includes lipolysis. It promotes lipolysis so that the fatty acid level is increased, which can be used as an energy source by the cells. Does not have much effect on amino acids and muscle protein. The major stimuli for secretion, that is sympathetic stimulation during periods of stress and exercise and also during fasting states. Primary role in metabolism, it involves provision of energy for emergencies and exercise. It makes glucose available for the cells to use, for skeletal muscles to use. Cortisol, it also increases blood glucose level. How it brings about gluconeogenesis, it promotes gluconeogenesis, it decreases glucose uptake by tissues other than brain. It is acting as a glucose sparer. So that the glucose is not being used by the cells, it is being spared. But it does not have that effect on the brain because brain cannot work without glucose. It also promotes lipolysis so that fatty acid levels are increased, also brings about protein degradation. So cortisol has an effect on protein. It is causing protein degradation because of which there is increase in blood amino acid levels. It also degrades the muscle protein because of which there is decreased muscle protein, which is seen in the state, especially in the hypercortisolism. The major stimuli for secretion is stress. Cortisol, along with the epinephrine, growth hormone, and glucagon, is a stress hormone. The primary role in metabolism, it involves the mobilization of metabolic fuels and building blocks during adaptation to stress. So it is making available these metabolic fuels. Growth hormone, it increases the blood glucose level by inhibiting the glucose uptake by muscles. It is also acting as a glucose sparer. So insulin was acting as a fat sparer, while these hormones, cortisol and growth hormone, these are acting as glucose sparer. It also promotes lipolysis and it is also promoting amino acid uptake because growth hormone is involved in growth protein synthesis. So it is promoting the amino acid uptake. So the levels of amino acids in the blood are actually decreasing. It also causes the increase in muscle protein, which is its major growth effect. It is causing the protein synthesis. It is promoting the protein synthesis, inhibiting the protein degradation, and it is actually promoting the synthesis of DNA and RNA so that more protein is formed. The major stimuli for secretion of growth hormone are deep sleep, stress, exercise, and hypoglycemia. There are other stimuli as well. Primary role in metabolism, it promotes growth. It has little role in metabolism as such. However, it causes mobilization of fuels plus glucose sparing in extenuating circumstances. So in certain circumstances, it does act as a stress hormone and it is actually increasing the plasma glucose levels. So these are the effects of these major players of energy metabolism. Let's discuss diabetes mellitus now. Diabetes mellitus, it is a syndrome of impaired carbohydrate, fat, and protein metabolism. That is, all of the actions of insulin, these are now impaired. Insulin's effects on carbohydrate, fat, and protein metabolism are impaired in diabetes mellitus, which is a syndrome. It is caused by either lack of insulin secretion, that is, type 1 diabetes mellitus, or decreased sensitivity of the tissues to insulin, or even both of these same things. So, diabetes mellitus is basically a syndrome of impaired carbohydrate, fat, and protein metabolism. And the pathophysiology, it involves either there is a total lack of insulin secretion, that the beta cells are not functioning at all, or there is decreased sensitivity of the tissues to insulin. That is, the problem is lying at the level of the insulin receptors. So type 1 diabetes mellitus, it is also called insulin-dependent diabetes mellitus, that there is no insulin which is being formed by the body itself. So now this type of diabetes mellitus, it does require insulin from any exogenous source. It is caused by lack of insulin secretion, whereas type 2 diabetes mellitus, it is also called non-insulin dependent diabetes mellitus. In this type of diabetes, there is increased or normal amount of insulin, but that insulin is not able to act on its receptors. It is caused by decreased sensitivity of target tissues to the metabolic effects of insulin. The target tissues, they are not responding to insulin. In both of these types of diabetes mellitus, the result is increased blood glucose, and then there are certain other effects of lack of insulin or its inability to exert its action, which are characterized by dyslipidemia and unregulated protein metabolism. Now, what actually causes insulin resistance? There are certain causes of that. It is usually seen in obesity and overweight, especially when there is excessive visceral adiposity. So this type of adipose tissue, which is present around the viscera, it causes release of certain chemicals, certain adipokines, which actually causes the resistance to insulin. So that is why this obesity is dangerous. It promotes insulin resistance, especially when it is part of a metabolic syndrome. The metabolic syndrome is characterized by certain changes in the body, including obesity, there is hypertension, there is dyslipidemia, and insulin resistance. Excessive glucocorticoids, especially seen in Cushing syndrome or steroid therapy, they can also cause insulin resistance. Excessive growth hormone, acromegaly, these hormones, cortisol and growth hormones, they are also known as diabetogenic hormones because they bring about increased plasma glucose levels, which initially stimulates the pancreas to produce insulin. And there comes a time when the pancreas actually becomes exhausted by producing insulin in increased amounts. So the beta cell function, it actually ends up decreasing in their hyperstate of growth hormone and glucocorticoids. However, glucocorticoids also bring about resistance to insulin, whereas growth hormone, it actually causes exhaustion of pancreas as well. Then in certain physiological states in pregnancy, the glucose levels are high. It can also cause gestational diabetes to develop, polycystic ovary disease. It also causes insulin resistance, lipodystrophy, autoantibodies to the insulin receptor. It makes sense. Mutations of the insulin receptor, mutation of the peroxisome, proliferators, activated receptors, these are involved in the insulin pathways. Mutations that cause genetic obesity. Hemochromatosis is a hereditary disease that causes tissue iron accumulation. So these are some causes of insulin resistance. It is pertinent to remember insulin resistance, which occurs in obesity, effects of excessive glucocorticoids and growth hormones, pregnancy. These causes of insulin resistance, they have to be remembered because these are the common causes. Now let's differentiate between type 1 and type 2 diabetes mellitus. The number one feature is age of onset. The type 1 diabetes mellitus is usually seen in young individuals. Type 2 diabetes mellitus is seen in older individuals. Body mass is low in type 1 diabetes mellitus, or it could be normal because of the impaired effects of insulin. Insulin is not even present, so there is protein degradation, because of which the body mass is decreased. In type 2 diabetes mellitus, it is associated with insulin resistance, so there is usually visceral obesity. Plasma insulin levels are low or absent in type 1 diabetes mellitus because the beta cells, they are not functioning, insulin is not being produced. In type 2 diabetes mellitus, there is normal to high plasma insulin level. Initially, the plasma insulin levels, they will be normal, or they can even be higher because there is increased blood glucose levels. Blood glucose is not being lowered because insulin is not able to exert its effect. So the glucose uptake by insulin sensitive cells is reduced. That is why insulin is continuously being stimulated by increased plasma glucose levels. So its secretion could actually be high. However, there comes a time when the beta cells actually become exhausted. In this case, the insulin levels will actually become lower. So the insulin levels, plasma insulin levels are variable in type 2 diabetes mellitus. Plasma glucagon levels are high in type 1 diabetes mellitus because the blood glucose is not being made available to cells. That is why in response to that, the plasma glucagon levels are high. In type 2 diabetes mellitus, these are high as well, and they are even resistant to suppression. Plasma glucose levels are increased in both type 1 and type 2 diabetes mellitus. Insulin sensitivity is normal in type 1, that there is decreased or lack of production of endogenous insulin. However, if exogenous insulin is administered, the receptors are working just fine. So these cells are responsive to insulin. However, insulin sensitivity because of the resistance to insulin is reduced in type 2 diabetes mellitus. Type 1 diabetes mellitus, insulin is necessary. It has to be administered because there is no production of endogenous insulin. For type 2 diabetes mellitus, weight loss is encouraged to reduce the visceral obesity and to improve the insulin sensitivity. Bariatric surgery is also done for weight loss to promote weight loss in which stomach size is decreased. Then there are certain drugs which are used to increase the insulin levels and to improve insulin sensitivity. You'll see them later on. So why diabetes mellitus is dangerous and why the symptoms which appear in the diabetes mellitus, they actually appear. So insulin deficiency, it affects the metabolism of all of these metabolites, carbohydrates, fats, and proteins. And this impaired metabolism has these consequences which bring about the characteristic features of diabetes mellitus. So let's just look at them one by one. In the presence of insulin deficiency, there is increased hepatic glucose output. The liver is sensing that the glucose is not being made available to cells. So for type 1 diabetes mellitus, insulin is necessary. It has to be administered because there is no production of For type 1 diabetes mellitus, insulin is essential as there is no production of endogenous insulin. It has to be administered from the outside. So insulin is the therapy for type 1 diabetes mellitus. In type 2 diabetes mellitus, weight loss is encouraged to improve insulin sensitivity. Bariatric surgery can also be opted for, and because it also reduces the For type 1 diabetes mellitus, insulin is the therapy because insulin is required as it is not being produced endogenously. ये भी है. For type 1 diabetes mellitus, insulin is essential because it is not being produced by the beta cells of the pancreas. In type 2 diabetes mellitus, weight loss is encouraged to improve insulin sensitivity, and for that, bariatric surgery could also be opted for. It decreases the stomach size, because of which the food intake can be decreased. And then there are certain oral hypoglycemic drugs which can be taken to improve insulin sensitivity and to increase the release of insulin from the pancreas. So why exactly diabetes mellitus is dangerous? What are the impacts of insulin deficiency? Insulin deficiency is going to cause impaired metabolism of three major metabolites we had seen: carbohydrates, fats, and proteins. How it is going to affect that, we are going to see them subsequently. Now let's just look at them one by one. In the presence of insulin deficiency, there is increased hepatic glucose output because glucose is not being made available to the cells. So the liver is going to synthesize more glucose. Along with that, there is decreased glucose uptake by cells. As far as the lipids are concerned, there is decreased triglyceride synthesis and increased lipolysis. All of these effects are opposite to the insulin because insulin is deficient in this case. So triglyceride synthesis, which was promoted by the insulin, it is not taking place, and lipolysis is actually occurring. And in the presence of insulin deficiency, there is decreased amino acid uptake by cells because protein synthesis is not being promoted in the presence of insulin deficiency, and actually protein degradation is occurring. So let's see the consequences of that. In presence of increased hepatic glucose output and decreased glucose uptake by cells, there is hyperglycemia. Hyperglycemia is going to cause glucosuria because the renal threshold is now breached. The glucose is going to appear in the urine. Because of the increased amount of glucose in the tubular fluid, it is going to act as an osmotic agent, and it is going to promote the osmotic diuresis. Because of this osmotic diuresis, there is going to be polyuria, increased production of urine. It is one of the characteristic features of diabetes mellitus. These patients, they present with polyuria. Because of this polyuria, water loss, there is going to be dehydration. This dehydration then causes polydipsia, which is increased thirst. This feature is also seen in diabetes mellitus. Presence of polyuria, increased urine production, there is increased thirst. Because the dehydration is sensed by the osmoreceptors and which promote the thirst mechanisms. Also, because of the decreased glucose uptake by the cells, the intracellular glucose deficiency ensues, which causes polyphagia, that is increased desire for food or excessive eating. So these features, they are seen in diabetes mellitus, and this is their pathophysiology. As far as lipids are concerned, because of the decreased triglyceride synthesis and increased lipolysis, the blood fatty acids level is going to increase because these are going to be used as an alternative energy source. When fatty acids are used as an alternative energy source, the production of ketones or ketogenesis is encouraged and ketosis results. This ketosis can then cause metabolic acidosis, which exacerbates the diabetes mellitus symptoms. If there is decreased amino acid uptake by the cells, it is going to cause blood amino acid level to increase, and these amino acids are then going to be utilized for the gluconeogenesis, which is further going to increase the plasma glucose levels and exacerbate all of these symptoms. In the presence of protein degradation, excessive protein degradation, obviously muscle wasting is going to occur, which is going to cause weight loss. The weight loss that is seen in association with diabetes mellitus can be explained by the protein degradation and muscle wasting that occurs. So let's carry them on. So polyuria, which causes dehydration, and polydipsia, it is going to bring about certain other effects. So dehydration is going to cause decrease in blood volume, because of which peripheral circulatory failure can ensue. In the presence of decreased blood volume, because of the decreased blood volume, there is going to be decreased cardiac output. Decreased cardiac output is going to cause decreased arterial blood pressure and decreased perfusion, especially to the brain. It is going to cause low cerebral blood flow and also to the kidneys, where renal failure can occur. Because of the dehydration, the cells may actually start shrinking because the ECF volume is now low, and the fluid is going to move from the intracellular compartment into the extracellular compartment, and because of that, the cells can shrink. This cell shrinking can especially damage the neurons. The nervous system malfunction can then occur. And both of these things, renal failure and low cerebral blood flow, these can predispose an individual to death. Ketosis, on the other hand, which had occurred because of the increased fatty acids level, it can cause metabolic acidosis. As a compensation for that, there would be increased ventilation. It is seen in diabetic ketoacidosis. There is a special pattern of respiration, which is known as osmosis breathing, which is characterized by hyperventilation and deep sighing breaths. The metabolic acidosis can result in diabetic coma, and all of these factors, they can cause death in an individual suffering from diabetes mellitus. So these are the consequences of impaired carbohydrate, lipid, and protein metabolism in the case of insulin deficiency in diabetes mellitus. So what is the diagnosis? Diagnostic criteria for diabetes mellitus, it is usually the plasma glucose levels, which can be measured by fasting and random blood glucose samples. These are taken, they are cut-off values, which help us to assign individuals with impaired carbohydrate, lipid, and protein metabolism into various categories, pre-diabetic or diabetic categories. Glycated hemoglobin levels can also be measured, which give us the indication of glucose metabolism over a longer period of time. To 120 days, this glycated hemoglobin is present inside of the RBCs. So it depends upon the lifespan of RBCs. Oral glucose tolerance test also gave us an indication of diabetes mellitus, and then urinary glucose levels and also urinary ketone levels in the cases of diabetic ketoacidosis. So the treatment of diabetes mellitus type 1, insulin is required. For type 2 diabetes mellitus, lifestyle modification, oral hypoglycemic medicines, and weight loss surgery can be undertaken. These are some of the oral hypoglycemic drugs which are used in case of type 2 diabetes mellitus. These drugs, they act as insulin sensitizers, or they improve the release of insulin, or they even inhibit hepatic gluconeogenesis. Some of these drugs are thiazolidine diones, which act as insulin sensitizers. Then there are biguanides, metformin, which is a commonly used drug. It inhibits hepatic gluconeogenesis and the action of glucagon. It causes increased glycolysis, increased peripheral glucose uptake. That is, it increases insulin sensitivity as well. Sulfonylureas, they close potassium channel in the pancreatic beta cell membrane, and we have seen that this channel, the closure of this channel causes cell depolarization, which then opened up the voltage-gated calcium channels and caused the release of secretory vesicles. So insulin release is actually promoted by sulfonylureas, which act by inhibiting the ATP-sensitive potassium channels. They close those channels. Then there are certain drugs which are known as incretin drugs. They mimic the action of glucagon-like peptide 1, which also increases the release of insulin from the cell. Then there are certain inhibitors of the glucagon-like peptide GLP-4/1 deactivators. So when these deactivators are inhibited, the GLP-1 can exert its action even more. Then there are certain drugs which inhibit the sodium-dependent glucose transporters in the kidneys, so that glucose is not reabsorbed and it is excreted in excessive amount in the urine. So these are mechanism fraction of some of the drugs. You can see them just to reiterate the importance of improving insulin sensitivity and inhibiting the hepatic gluconeogenesis and improving the release of insulin from the beta pancreatic cells. On the other extreme, there is a condition which is known as insulin shock. It occurs in the setting of hyperinsulinemia, which could be due to an insulinoma, which is a tumor of an beta pancreatic cells. It produces large amount of insulin hormones, which bring about hypoglycemia. Now, this hypoglycemia, it damages the brain and can induce coma in an individual. If the blood glucose levels, they fall into the range of 50 to 70 milligrams per 100 ml, that is, they are far lower than the normal glucose levels, the CNS, it becomes excitable. The neurons, their excitability increase initially, and it results in hallucinations, nervousness, trembling all over, and the person may break out in a sweat. As blood glucose levels, they fall to even lower levels, clonic seizures may ensue and person may even lose consciousness. As the glucose levels fall still lower, the seizure cease and only a state of coma remains. So this insulin shock, it is quite dangerous and it is treated with the intravenous infusion of glucose to promptly restore the glucose levels. So with insulin shock, we conclude our lecture. These are the study resources which were used to prepare the lecture slides. You can use them to study on your own. Thank you so much. You can contact for any of your questions on any of our social media handles.